Hi guys, good morning to you. This is Dr. Satyabama here for Raaonline, and the topic for today is about Osteoradio Necrosis. And this is actually a sequelae to your osteomyelitis and infections of the bone. So today we are going to be dealing in detail with the necrosis of the bone that happens, how to go about managing that, and a note on bisphosphonate-induced osteoradio necrosis as well, because we have many cases being reported as that due to the bisphosphonates being given, especially the intravenous ones for patients on cancers of the breast, lungs, and renal. They are being given bisphosphonates, and then they end up having BRONJ, bronch, we call that, bisphosphonates induced osteoradio necrosis of the jaws. Okay, so let's go on. So what is osteoradio necrosis and what happens in this? The endothelial cells in the bone are being killed. Endothelium in the bone, which is blood vessels forming in the bone, are killed. So no blood supply from within the bone, and it's an irreversible process. Where is it more common? It's more common with the mandible, because mandible has bicortical bone and it is more cortical in nature and it needs that blood supply. But when that endothelial cell is done with and dealt with by this radiation, it does not get blood supply. The periosteal supply is not good enough, and hence it results in radionecrosis of the jaw. It's quite long lasting and permanent, and you need to put these patients on hyperbaric oxygen therapy along with surgical management of these patients. So when we're looking at osteoradio necrosis per se, the main problem with non-healing wound is three things. One is hypoxia, hypocellularity, and hypovascularity. This is a very common problem that people do not know. The postgrads blink, the undergrads are like, what are you talking about, ma'am? I don't know. Okay, so hypoxia. Oxygen supply is not there, endothelium is not there, blood is not there, so hypoxia happens. So when hypoxia happens, when oxygen is not there, what happens? There is no growth, there is no cellularity, there is no vascularity. So all these tissues will become, when there is nothing there to supply blood and revitalize the bone, it will become dead bone, it will become infected bone, it will become problematic bone. Dead and liquefied dead cells is pus. Right? Okay. So you have hypoxia, following which you have hypocellularity and hypovascularity. These are the three things that is very common in your osteoradio necrosis. What is the etiopathogenesis here? It's secondary to radiation, most often to cancer, and it's dependent on the quantity and the quality of radiation given. Primary radiation is 5,000 grays. Okay. Tissues, the end arthritis become obliterated, resulting in ischemia and reduced osteocyte population. Okay. So what are the problems patients complain of? What is the sign and symptom that the patient comes to you with? Pain with exposed non-vital bone, especially, with this bone that you're looking at. When you're looking inside the oral cavity, you will find that the bone that is exposed is raw, is open, and it will show signs that it is not healing. It is going in for further deterioration. Okay. So anything that will show that there is an exposed bone after your surgery, you closed it primarily, and then you find that the sutures are given away and there is bone exposure, you must think, what's happening here? Bone is exposed, vital bone is not there. I'm slowly losing it. Then patient will have, if the muscle soft tissues are involved, muscular involvement happens, trismus will be there, patient will be toxic, which means there will be temperature, there will be pulse rate rise to tachycardia, there will be temperature rise, okay. Whether there is a fistulae associated with it or not, whether it is intraoral or extraoral in nature, which will be draining the pus that's being collected, depends on when you're seeing this patient. Intraorally, if it is present and patient is being there a couple of days and he's come back with a problem, then okay, you caught it at the right time. Patient is thinking, yeah, I'm absolutely fine, yeah, the pain is there, but I can't go back now. I'll let go, I'll wait for another week or 10 days or 1 month and then come back, and an extraoral sinus and a fistulae which is dribbling and drooling with pus. We are in a soup, right? So what are the tissues that are involved? How much is the infection that is there? What kind of induration? Is there a recurrence there? Is there a fracture associated with it? and take my radiograph. I've taken a culture sensitivity test of the pus that I've collected. I've sent it for investigation. I've taken a radiographic picture and I see moth-eaten appearance. Yeah, I know what I'm looking at. Okay. Then following which you will have sequestrum and involucrum following, right? So the management, like we talked about the osteomyelitis, here again we will divide it into a medical and surgical treatment, and the hyperbaric oxygen therapy is a must. Earlier days, 15 years ago, 10 years ago, HPO was not there in Chennai and very costly as well. But now, yes, we have many centers that are doing HPO therapy. Yeah, it is still on the costlier side, not very commonly done, still on the costlier side, but at least it's available and it's not very costly. But the number of dives, the number of sessions that you go has to be increased depending on the rate, depending on the type, and depending on the aggressiveness of the infection and the nature and the site of the infection that is present. Okay, so what do you do? What do you do? Medically, you manage the patient, make sure that the patient is absolutely fit. Medically, you put them on antibiotics, give a local irrigation, and then if necessary, you can go in for these antibiotic beads as well. So medical management is rehydrating the patient, make sure patient is given good antibiotic therapy, make sure that the patient is otherwise pretty okay. The comorbidity conditions are well under control, especially if they have a renal problem and if their LFTs are fine, whether their LFTs are fine, is their cardiac problems fine, all that, if that the comorbid conditions are being looked at. So any patient when you treat, guys, this is one thing that you must remember. This is slowly coming off our system in India. Patients, are being looked at by the medics, and they say, a DSA will come in and say, no, sir, this particular patient is, the potassium levels are low, the sodium levels are high, and, I need to correct this. Then after some time, you will have the ENTs come in and say a different thing altogether. Then you have the cardiothoracics come in and say, oh, she had a stent given, blah, blah, blah. So everybody is looking at their field, not looking at the patient as a whole. Okay, the point to be taken here is whatever treatment you're doing and whatever surgery you're doing, post-operatively, perioperatively, the main take home here for you is you must ensure that this particular patient is being looked at as a whole. Okay, are cardiac systems fine, respiratory systems fine, renal fine, liver fine, okay, no other issues, otherwise patient is absolutely fine, no comorbid condition, everything is under control, everything is being monitored. Okay, then you also look at your surgical area, your surgical expertise there, and treat that as well. So to know that, you must be very strong medically. Please do ensure that in your first year of postgrad or in your third year of final BDS, you make sure you go through your medicine book, and please don't read some XYZ books. Go through good books that have been prescribed by the universities, the respective universities. Okay, local books for dental surgeons. Books for dental surgeons is not sufficient enough. You need to, that's one thing I want to say, you're off the mark, guys. You need to make sure you read good medical books, medical and surgical books, to gain good knowledge. Otherwise, you will be half-baked and you will not be able to treat your patients quite very well. Okay, right. So move on.